welcome to Voices of Wisdom, Tyro's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where over the next 15 minutes, we will be talking to international experts who will share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I am your host, Dr. Janice Pasieka. I'm a surgical endocrinologist in Calgary, Alberta, Canada. I am excited to be your host on Voices of Wisdom podcast, in addition to the other educational materials on thyroid cancer management that Tyros has been providing through our website and weekly webinars. We hope these podcasts will complement our other activities by providing short, easily to digest sound bites for clinical issues that we all face in the treatment of thyroid cancer patients. In each episode, I will be joined by a distinguished international guest who will bring their unique perspective and expertise to the discussion. Today, we are going to talk about the changing paradigm of thyroid cancer, that being active surveillance. I am thrilled to welcome Eyal Robenshtok from Rabin Medical Center and the head of the Thyroid Cancer Unit in Tel Aviv, who brings invaluable insight into this area. So whether you're a surgeon, endocrinologist, pathologist, medical oncologist, or nuclear medicine specialist, these podcasts promise to be pivotal resource in your quest for knowledge in the care of thyroid cancer patients. So let's get started and first bring to the microphone Dr. Robenshtok. Welcome.
Hi, Janice. Great to be with you. We have a very interesting topic today.
Eyal, over the course of our careers, there has been a shift in the treatment of well-differentiated thyroid cancer, from total thyroidectomy and even prophylactic node dissections to the other end of the spectrum, that of active surveillance. By definition, active surveillance is the ongoing follow-up of a known thyroid cancer. Could you outline for us what active surveillance looks like in your hands? And what are the selection parameters that you use and what is involved?
Well, first, we know that in patients with intrathyroidal small thyroid cancer, active surveillance is safe. Now, how come we have cancer when we just look at it and not go to surgery? So if we look at the big picture, we've learned over the years that occult thyroid cancer is very common. And we actually diagnose only a small minority of thyroid cancer. In fact, for every one patient that we diagnose with thyroid cancer, there are around 20, maybe even 30 people who live their lives perfectly well without knowing about the disease. So we know that of these cancers, let's say around 6% in the population, depends what population you look at, only a minority will grow and spread and will become clinically significant. So when we diagnose a small thyroid cancer confined to the thyroid, most chances it will remain stable and we can just follow it with periodic ultrasound. If it remains stable, then we prevent unnecessary surgery, and if it grows, we'll take it out. Now, as of today, the decision if a lesion is suitable for active surveillance is based mostly on ultrasound. We have other testing, including thyroglobulin, antibodies, molecular markers, but they have little value in predicting which of these cancers will grow and which will not. Now, the best candidate are patients with small, solitary, papillary thyroid carcinoma, which is completely surrounded by normal tissue. Most use 1 centimeter threshold, but some centers even go up to 1.5 centimeters, like in Memorial Sloan Kettering. So if we have this, it's easy to follow. But even if we have multifocal disease, so we have more than one lesion in the thyroid, or if it's near the capsule without invasion outside the thyroid, we can still follow it. It's not ideal, but we can still follow it. And we call this group appropriate for follow-up. And if it's only in the thyroid, it's ideal for follow-up.
Okay. So you say that you do not use molecular testing. So if somebody did come with a small thyroid cancer that's BRAF positive, you would still be willing to offer them active surveillance?
So traditionally, looking at BRAF mutations, we know these tumors behave more aggressively. But about 50% of papillary thyroid carcinomas have BRAF mutation, and we see them in low-risk tumors, in intermediate risk, in high-risk tumors. We know that if a patient with the BRAF mutation needs radioiodine treatment, the response is less good than in other mutations, but it doesn't tell us that this tumor is going to grow. Many of the micro-PTC that go undiagnosed in the population have BRAF mutation. So BRAF by itself is not an indication for surgery. We have a very small minority, about 1 to 2%, that have high-risk mutations. Let's say BRAF with THRT mutation. In these cases, we will go for surgery, but the yield of molecular markers is pretty low. So it's not ready still today for routine practice. Hopefully, we're going to have better markers of growth, not saying if something is benign or cancer, but of growth, and then we'll be able to use it for the decision who to follow and who to send to surgery.
Yeah. And so expanding on that, what patients do you not offer this to? Because I'm sure there's patients that come to you and say, can't we just watch this? I've read about this active surveillance program. Who do you not offer it to?
Okay, so you're right that active surveillance is not for everyone. So cancers that bulge out of the thyroid, and we suspect they have extrathyroidal extension, will send to surgery. If the tumor is adherent to vital organs, such as the trachea or recurrent laryngeal nerve, will go straight for surgery. Now, apart from the cancer itself, we also look at the patient. Not all patients want this approach. So you can have two patients with exactly the same tumor. One will say, I prefer not to have surgery if I don't have to. And then the other one will say, take it out now. I have cancer in the neck. I want it out. So we have the cancer, the location of the cancer, if it's multifocal or not. And lastly, we have special populations like pediatric patients. In this group, statistically, the chances of growth is really high. And if we have a patient that's not going to come for follow-up for some reason or another, again, we'll go to surgery.
So what is that follow-up? Like how often? And do they have to come to your center? Is it a dedicated ultrasonographer? What's actually involved?
Okay, so the routine plan for these patients is ultrasound every 6 months within the first 2 years, and then yearly. And after 5 years, sometimes we stretch it to 1.5 or even 2 years. Preferably, the ideal situation is if you have an expert sonographer who follows the patient. Each sonographer can measure the tumor in a different angle and get a different number. So preferably, it's in the same center when they compare the images.
So you said, at 5 years, you may de-escalate it. The data, certainly from Japan, would suggest that younger patients are more likely, when they go into an active surveillance program, just delaying the inevitable. They're the ones that seem to have growth and a progression over time. Has that been your experience?
If you look at the data from Japan, indeed, the risk in younger patients for growth is significantly higher. They even calculated the lifelong risk of growth. In young patients, let's say around the 20s, the lifelong risk is about 30%. So still most will not grow. And over the age of 60, it's around 5%. Still, most tumors remain stable. And some argue that if you're just delaying the surgery, you didn't do anything. But if you think about it, about the patient, delaying surgery is not such a bad thing. For example, around 1% of patients will have vocal cord paralysis, even more will have palsy. So if we can delay that by several years, it's also a good thing. And because delaying complications is a good thing. And some patients really fear the need for levothyroxine therapy for life. It's about 30% of patients that will need therapy after lobectomy. And most will prefer to start this medication later rather than earlier. And we can think that maybe in 5 or 6 years, we're going to have other approaches and more advanced molecular markers that will help us stratify who really needs treatment or not. So delaying treatment is not a bad thing.
Right. I think that this really does then involve quite a complex conversation to make sure that the patient is aware of their options. And how do you reassure them that even if it grows, or even if, heaven forbid, there's now lymph node metastases, that they're going to be okay?
So I usually use some images. For example, I show them the study from the New England about the thyroid cancer epidemic in parentheses from Korea, and tell them that most people go live their lives without knowing about their thyroid cancer. And by mistake or by chance, we found there's little thyroid cancer. We discuss the numbers, the risk of growth, that most cases won't need surgery. And we do discuss what happens if there's growth. That's one. If there's only growth, it's not a problem. We go for surgery. The only caveat is there's a small number of patients, let's say 1 or 2%, they're going to have lymph node metastasis detected during follow-up. And in this case, they're going to have a larger surgery, total thyroidectomy, neck dissection, maybe even radioiodine. So the patients have to understand it, and they need to be on board. They need to understand what's going on and to accept the fact that not doing a surgery or delaying a surgery is better than doing a surgery now.
And just to put it in the real world perspective, what percentage of your patients are undergoing active surveillance at any given time?
So it's really interesting because over the last 6-7 years, there was a large shift, at least in my clinic locally. Let's say 6 or 7 years ago, when I suggested active surveillance, I think about a third of patients were interested, and many wanted to just go to surgery and get it over with. Now, in Israel, we have a very active Facebook group about dealing with thyroid cancer. And you have many patients there. Many of them are not happy with the surgery that they had. And they say, maybe I shouldn't have had it in the first place. Some have nasty scars. Some don't feel well with the thyroid hormones. Some have vocal cord issues. On this group, they tell new patients, you don't have to have surgery. Ask your doctor if you can just follow it. Sometimes I even have patients inappropriate for active surveillance, even with lymph node metastasis, coming to clinic and asking for active surveillance. So it's very interesting. It's not only us that change the way we do things. The patient has a social surrounding. They have a mother and a sister, and maybe someone they know in the workplace that had surgery. They have social groups. So in our case today, active surveillance is pretty easy to sell. And it's interesting. I guess there's a large variability between countries and between cultures.
My limited experience is that it was the older patients were quite content to avoid surgery, but the younger patients, after a couple of years, they then started getting anxious about this cancer in their neck and then wanted it removed. Has that been your experience, or are people very committed to active surveillance from the beginning?
So most patients that I have, after even young patients, after 2-3 years, continue with active surveillance as long as they see that the lesion is completely stable. It really depends on the team that you work with, because if everyone's on board, everyone knows this approach, active surveillance, then it's easy. They go to the sonographer, he tells them, oh, great, everything is okay, go back to the endocrinologist. Then it's easier. If you have a different sonographer every time and they tell them, wow, I see you have this suspicious lesion. Why didn't you take it out? Urgent. Go to the endocrinologist and tell them you still have this cancer. Then it's going to be really hard to follow. So we do try to keep these patients within a system, and sonographers and head and neck surgeons who are on board and that can support it. And I found when you have this sort of team, then it's easier to keep patients on board.
Yes, I think you're highlighting the important part, and it's a team effort that have to believe the data and believe that this is the right thing for that particular patient. So if we have to summarize, you would consider active surveillance in what type of patient?
So in patients, preferably older patients, but also in young patients with intrathyroidal thyroid cancer smaller than 1 centimeter, and in some excellence centers, it can be up to 1.5 centimeters, who are willing to participate in active surveillance, and as long as you have the team to do it.
And to summarize, active surveillance is not appropriate in what patients?
In patients who have cancer, which is in, we can say, unfortunate location. It can be bulging from the thyroid. It can be near the recurrent laryngeal nerve, can be splashed on the trachea. So the location of the thyroid, obviously patients who are very anxious and just want to take it out, and patients who can't or won't follow this protocol of follow-up, then will go for surgery.
Right. It's not ignore the cancer, it's actively surveilling the cancer. Would you agree?
That's true. Yeah.
Yeah. And would you agree with the statement progression is easily treated without a change in their prognosis? Is that a fair statement?
Yeah, I think it's a fair statement. The very few patients that I have who were in an active surveillance program and then had lymph node metastasis and had a larger surgery, all of these patients, it's only 2, both these patients were still content and still understood the risks and benefit of this approach. And they weren't angry or anything. We tried this approach, which was very logical. They were in this 1%. They had treatment. They're healthy today. So I do agree with this statement.
Eyal, this has just been a fascinating and very informative discussion. But before we wrap things up, I thought we should use each podcast to get a little extra knowledge for our listeners, something beyond medicine, and take advantage of our international reach. You have had the luxury of traveling and visiting many places in the world. Can you tell us what your favorite city is to visit and why?
Okay, so this was a family discussion, and we decided about San Sebastian in Spain, which is in the Basque area. It's just a fabulous city near the seaside. You have wonderful architecture and seaside and art and views, and just a lovely place to go to.
Oh, well, I've never been. I will have to explore that in the future. That brings us to the end of our podcast, Voices of Wisdom. I'm Janice Pasieka, and it has been an absolute pleasure to host today's discussion on active surveillance. I want to extend a special thank you to our guest, Dr. Robenshtok, for his invaluable pearls of wisdom. If you liked our podcast, please subscribe to our webinars, which air live every Friday morning, 8 a.m. Eastern Standard Time. This is a series for thyroid clinicians and researchers that cover breakthroughs in thyroid cancer research and treatments in the form of journal clubs, state-of-the-art lectures, and multidisciplinary tumor boards with lively panel discussions. Just visit tyro.expert/subscribe or click on the link in the description. If you have any questions or suggestions for future podcasts, email us at voicesofwisdompodcast@gmail.com. I want to thank you all for joining us today, and I want to leave you now with a quote from one of my heroes, Sir William Osler, who said, "The fundamental law should be ingrained that the starting point of all treatments is in a knowledge of the natural history of the disease." How true is that, especially when considering the treatment options for patients with low-risk, well-differentiated thyroid cancer? And with that, I wish you all a pleasant day. Keep smiling.